We move to the second speaker. May I introduce Dr. Nantiskarn Chanpen from the intervention radiologist from the Chulalongkorn University. She will present how we did with the endovascular type 2. So Dr. Nantiskarn, please.
Thank you. Thank you for the introduction and for inviting me to share the experience about endovascular treatment for type 2 endoleak. It's the problem that every operator of the EVA will have to face. Type 2 endoleak can occur quite often. The prevalence is about 10 to 20% after EVA, and among this, 30 to 40% become persistent and needed treatment, and 1% can go on to rupture. The decision to treat according to the current practice guidelines, according to SVS and ESVS, we will start planning to treat type 2 endoleak when the sac expansion is about over 10 millimeter or over 5 millimeter with a visible patent inflow and outflow arteries, or when the patient has symptoms. The arterial side branches that account for type 2 endoleak can be from IMA and the lumbar arteries, and also the pelvic tributary to the lumbar arteries, the median sacral artery, and also the accessory renal arteries. For the risk factors that contribute to persistent type 2 endoleak are the patent IMA, the increased total number of patent lumbar arteries, and also the bigger size of that feeding vessels, or when you can identify the endoleak that on the CT scan, it persists from the both arterioles and delay phase. It determines that the leak is quite rapid flow and needed for the treatment. The larger of the endoleak cavity or the lower thrombus volume. This is the data from Chulalongkorn. We collected 105 patients post-EVA procedure during 2010 to 2018. We demonstrated about 18% prevalence of persistent type 2 endoleak, and the significant factors that predictors that we found are the patent IMA, regardless of size, and also the patent L3 pair within the aneurysm sac. This data is quite relevant with the former data elsewhere. So when we talk about the type 2 endoleak management, we can treat it at two stages: preoperative prophylaxis measure or the post-operative treatment. For prophylaxis, it's the preemptive aortic side branch embolization. This procedure, from the data from the systematic review and meta-analysis, they demonstrate that it can contribute lower rate of type 2 endoleak, also less frequency of the sac growth, lower rate of reintervention with low and minor complication. However, serious complications such as ischemic colitis can also happen and has been reported. When you think about side branch embolization, you need to consider the anatomical at risk. So it suggests that the IMA of the size more than 3 millimeters, the patent lumbar arteries of more than 4 branches, or the size more than 2 millimeters, with or without the patent ipsilateral internal iliac arteries. For the technical, the safe area for the safe embolization is the most proximal segment of the arterial branch. For lumbar arteries, you can easily remember to embolize the segment before any medial branching of the arteries. So this area before the branching of anterior spinal arteries or Adam-Kivik. And for the IMA, is before the branching of the left colic arteries to spare the distal collaterals to supply the bowel loops. But this procedure has some challenges and limitation as well. It can be very difficult to cannulate the side branch due to the high tortuosity of the vessel and large diameter of the aortic, the diseased aorta that that has a problem. It's a time-consuming procedure and requires multiple instruments, and the patient and also the operator needs to expose higher radiation dose and also more contrast material and administration to the patients. But this limitation can be minimized by the use of the fusion and mapping software. This is the case that we demonstrate the multiple lumbar pairs before doing the EVA procedures, and the size is more than 2 millimeters. So we decided to preoperative embolization prophylaxis. I used the preoperative CT scan and fusion technology to guide the target vessel for embolization. So this technique, you do not need to do the aortic angiogram, so there's no added radiation exposure or the contrast during the first identification of the side branch. And it facilitates the procedure, and we can do it much more easier. Another preoperative measure is the preemptive non-selective sac embolization. This technique is to fill the sac with embolic agents such as coils or fibrin glue, using within the sac, outside the graft, using the guide wire that were left outside the graft. So it was done during the EVA procedure and no added treatment session. So it's quite easy because you don't need to select into selective into the side branch. And it's reported to reduce the type 2 endoleak, the sac size, and the reintervention rate during early and midterm follow-up, but it still does not reach the long-term success. This is another data from United States in 2020. They can demonstrate 100% success with no non-target embolization and reached 3-year freedom from type 2 endoleak as high as 87.1%. So when it comes to the treatment, there are many techniques for the treatment of type 2 endoleak. There are either transarterial embolization, direct sac puncture, transsealing or perigraft, or even transcable or transgraft. So the aim of the treatment is to completely embolize and occlude from the inflow artery, the endoleak sac itself, and also the outflow arteries. Because if you only embolize the inflow artery, and the outflow artery will become the inflow to feed the endoleak sac. And when the sac pressure is increased, the collateral arteries will open up and act as an outflow instead, and it will recur. The embolic materials that we mostly use are the coil, the plug, and the liquid embolic materials such as glue or onyx. For glue, it permits rapid occlusion, but it's quite difficult to control because it can form the cast at the tip of the catheter quite rapidly, and it may not get to reach to the target that you want to embolize and may reflux to the parent artery and will be a non-target embolization. But it's very useful to use in adjunct with coils to enhance the slow flow within the large diameter of the sac. And we remember if each session of the glue injection, you will lose the microcatheter access. So if you cannot completely embolize the endoleak sac within one injection, you will need to start over the cannulation again. Ornix or EVOH, it is a main player for type 2 endoleak now. It has much more controlled delivery by plug and push technique. So firstly, you form the plug at the tip of the catheter, and when the backward plug is dense enough, it has a higher pressure, higher resistance. So if you continually inject the onyx, it will find its way to the lower resistance space and reach to the more distal and completely fills the sacs more. But it's quite a take time procedure and quite expensive. First, that we mostly use is the transarterial approach, particularly in the case that CTA, you can trace the arterial pathway from the main artery to the feeding endoleak sac. It is most useful in case with endoleak from IMA. It's a flow-directed approach, so you have a good overview of the vascular anatomy and you can plan the procedure precisely. But it needs a long and tortuous pathway to reach to the target. So careful selection of the microcatheter and wires are very important. The report freedom from aneurysm sac expansion is as high as 81.5% in 1 year, but decreased rapidly within 5 years. This is the case example. It's the type 2 endoleak from L2 and L3 level from the iliolumbar arteries that anastomosis with the lumbar arteries. And you can see the flow directions is from the L2 downward to L3. But the furthest microcatheter that I can get is at the L3 level. So if I use glue at this position, it won't reach to the target at L2 level. So I decided to use onyx in this case. After forming the plug around the microcatheter and continuing to push forward, you can see the nidus, the onyx fills the endoleak sac here, but it does not go further. So I waited for about 2 minutes more and then continue pushing forward. You can see the onyx slightly goes up to the L2 level and reach complete embolization. Another technique is the direct sac puncture. Mostly we use on the back, translumbar approach more than transabdominal. We use in the case that we cannot trace the arterial feeders from the major arteries or there's no access. It's easier because you get directly to the endoleak sac itself, but if you get to the sac, but during injection, you cannot identify the arterial branches. That means if you embolize, it will not get to the arterial feeders or the outflow arteries. So it suggests a higher chance of the failure. Imaging guidance can be anything, ultrasound, fluoroscopy, or cone beam CT with the guidance software or the CT guidance. This case, you can see the endoleak sac is here and the thrombosed aneurysm sac is approximate to the anterior abdominal wall. So it's easy to use ultrasound as a guidance tool to get the needle to the endoleak sac here. This is the needle in the endoleak sac. And once you get into the endoleak sac, you can observe the back bleeding from the needle and you inject the contrast to confirm the endoleak and fills the space with any liquid embolic materials. This is another case. The endoleak sac is deep within the abdomen. It's not possible to use the ultrasound as a guidance tool. So I use cone beam CT from the back. It's translumbar to guide the needle to the endoleak sac here and fills the space with glue. Another approach is the transsealing or perigraph approach. It's the direct sac access also, but from the distal attachment of the graft through the potential space between the graft and the arterial wall. It can reduce the risk of extra aortic leakage or other organ injury because it's go from intravascularly, but it's quite difficult because you need a stable catheter to engage this very small potential space. So we consider to use it in a case of lack safe access from direct puncture. But this case example is the ideal example to use the transsealing approach because it has combined type 2 and type 1B endoleak. So you have a gap in the distal attachment to get the catheter inside the potential space between the graft and the aortic wall. And use a microcatheter to select into each branch using the overlay image to guide the catheter and then embolization of each branch you identified. So I use coil most of the branch. But this final branch here, I cannot place the stable microcatheter inside, so I need to use glue and be careful control of the glue to make it do not go further to the distal. Then you can see I also place the coil inside the large endoleak sac to promote the thrombosis within the sac, and followed by distal extension of the graft. Another technique, transcaval approach, we can do it also when the endoleak sac is above the IVC by using the needle through sheath system, or like the Yoshida Roche tip set, and any guidance such as fluoroscopy with the anatomic guidance, or the transabdominal or IVUS guidance. It has less bleeding complication, and we do not need to embolize the tract once the sac has completely filled. This is the diagram show how to do it. We use the sheath and the needle from one vein groins, and another IVUS guidance from another side. And when we puncture inside the endoleak sac, we fill the space with liquid. Mostly we use onyx. And when the sac is completely embolized, we can draw back the catheter safely. Transgraft approach is pretty similar, but you can use like a coronary laser catheter or transeptal needle to puncture the graft, and the same concept. If you completely embolize the sac, you do not need to embolize or seal the puncture hole. This is the special case. It's type 2 endoleak that caused from the multiple lumbar arteries that caused the sac enlargement, and it compressed the left common iliac vein to cause like a May-Turner syndrome. And in longer term, it becomes a fistula to the left common iliac vein, and act as an outflow. So this endoleak is a high flow endoleak. After the multiple session of lumbar artery embolization, this is an angiogram from the artery through, and this is the endoleak sac, the AVF, and the outflow left common iliac vein. So in this session, after I already embolized the artery, I use the transvenous, go from the vein, get inside the sac, through the AVF, get inside the sac, and fill the space. It's quite a large volume, and onyx is quite expensive, so I use coils combined with glue to fill the space. Okay, so in summary, first step is to correctly diagnose the type of the endoleak that leads to the complete and successful treatment of the endoleak, and preoperative evaluation of the anatomical predictive factor for the type 2 endoleak. And you need to decide whether to do the prophylaxis or not. You need to weigh it with the risk and benefit and all the resource of the procedure. Using all the advanced technologies such as CT, cone beam scan, IVUS, or any guiding software can facilitate the procedure and make it much more easier and be improvised. Use all the combined technique and embolization material for any particular patient, and surveillance in every case, because recurrence can always happen. Thank you.
Thank you very much, Dr. Nantiskarn, for the very interesting lecture. So is there any question from the floor first? Yeah, so we would like to have some comment from panelists.
So may I have some questions about the accessory renal artery?
Okay.
So basically sometimes we have heard that the renal artery is an end-on artery. So do we need to embolize that if we have to cover the accessory renal?
Yeah, actually, yes, because it's real anastomose with a capsular branch, and can finally, if the main artery is already blocked, it can become the collateral. And when you already exclude the aorta, you have no access to go from the capsula, like very small artery. So it's better to do it first.
I have a few questions. So the first one is for prophylactic prevention. How much embolization is enough?
How much is enough?
Yeah.
Actually, currently there's no data, truly speaking. So we will embolize as much as possible that we can access, and do not increase the risk of the patient, like the contrast material or the prolonged procedure. Maybe you can stage procedure to do session by session if the patient can wait. But we still strict to the criteria of the major lumbar pairs will cause more percentage of endoleak and the size of the vessel.
Yeah. And so do you need to wait for some time after the embolization or we can do in the same procedure?
This is the procedure that prevents endoleak, not the spinal cord ischemia. Actually, you can do the EVA procedure, but if the patient has already poor collateral, like occluded celiac with compromised SMA or the internal iliac disease, it has higher chance of the spinal cord ischemia in that case as well. So it's suggested to be waited for about more than 10 days to form the collateral to supply the spinal cord.
Yeah. Yes. Yes, please.
Very nice presentation. Thank you very much. I'm always collaborating with my radiologist, and I always say that type 2 endoleak is a radiological issue. So you should elucidate this issue. However, my question is that are you successful with the type 2 endoleak management? Because my hospital data, only half of the patients revealed regression of type 2 endoleak, but another half repeated.
Yeah.
So I would like to know the results of the post-EVA type 2 management result.
You mean like the percentage of success? It's a nightmare for us as well. So we started, as I said, if you can trace the arterial branches, we go transarterial first, and it can fail if the arterial branch is very small and tortuous. Then we consider something else like direct puncture, and it still failed. We need to wait for the collateral to form, or the endoleak sac is getting bigger for easier direct puncture using different kinds of endoleak materials. And like we need to do it repeatedly, not only one chance, to give the chance for the treatment before we decided, okay, done, and that guys need to do the surgery to correct the endoleak.
So let me have a question. And after many sessions of the embolization techniques, some artifacts will be on the scan. How you recommend to follow this patient that have a recurrent endoleaks or not, or any follow-up techniques to identify endoleaks?
Okay. Now we still use the CT scan because MRI will cause more artifacts of the embolic materials, and you can do Doppler ultrasound if you can access, like the sac is quite superficial. It can demonstrate the endoleak very well, and also you can do the like 3D time resolving CT scan. It's collecting the data of the accumulative enhancement within the sac and correlate with the time frame. So it suggests that it's the true endoleak or not. Yeah.
May I ask a question about the preemptive embolization? even though we know that type 2 endoleak is quite very difficult to treat, like Dr. Masuda mentioned, like maybe 50%. But to do the preemptive, I still feel a bit reluctant to do it. A few reasons. First, you mentioned that the IMA in your series, it doesn't matter what is the size, it will cause endoleak anyway. So the 3 millimeters thing, I'm not quite sure that it will is that true? And majority of the type 2 endoleak we see in our hospital mostly is lumbar, not IMA. And if it's only IMA, that is easy to fix, I think.
Yes.
But the problem is the lumbar. So my question is, do you suggest to do the preemptive embolization for the IMA, or do you suggest to do it for the lumbar? But my concern is that the incidence of type 2 endoleak is only about maybe 20%, let's say, to the highest number. 100 cases that we do endo, 20 cases will have type 2. Within that 20, there will be a few that cause enlargement. If we do preemptive, then we do for free for over 90 cases, I guess. So I don't know what is the... So that confused me, so we don't do it yet. We kind of trying to get more information about that, which I think there will be some patients that will be beneficial for this procedure.
I totally agree with Ajahn Bumbrasit about the IMA, because treatment post-operative is pretty easy and we can reach to the target like almost of the time. So for IMA, if it's like not more than 4, I do not treat 4 mm. But the lumbar is something. Lumbar artery, if treated post-operative, it can be quite problematic. So if there's a strong indication, we starting to do more, but we don't have the protocol yet for now.
Yeah, thank you very much, Dr. Nathalie, for the great experience.